You know that feeling when you're trying to get your head around something important, maybe a bit complicated, and all the info just feels scattered?
Yeah, like trying to piece together a puzzle with bits missing.
Exactly. Well, that's what we're tackling today. We're doing a deep dive into a really significant health issue for our dogs, degenerative myelopathy, or DM.
Hmm.
Think of this as your shortcut to understanding what this condition is really all about.
Yeah, our goal today is basically to unpack degenerative myelopathy for you. We want to make it clear what it is, how it progresses in dogs, which breeds might be more likely to get it, and what the science is telling us.
Right.
We've gone through a lot of comprehensive info, and we're here to pull out the really crucial bits for you.
And this isn't some super rare thing only specialists see. The information we looked at covers, well, everything from the basic definition to the nitty-gritty of how the disease works.
The pathophysiology.
The genetics, how common it is, which breeds pop up more often, the signs to look for,
Yep, causes, diagnosis, treatment.
and the prognosis, the overall outlook. So we're really covering the bases to give you a solid picture.
And what's really striking, I think, and might make you think differently, is the connection this dog disease has to a human one.
Oh, right. You mentioned that.
Yeah, DM in dogs shares a genetic link with ALS, amyotrophic lateral sclerosis.
Lou Gehrig's disease.
That's the one. In humans. And the link is a specific mutation in a gene called SOD1.
Okay, let's dive into that. So first things first. In simple terms, what is degenerative myelopathy in dogs?
Okay, so at its heart, DM is a nerve disease. It's progressive, meaning it gets worse over time. It starts in adult dogs, and unfortunately, it eventually leads to paralysis.
And it's linked to that gene.
It's been found in lots of different breeds, and in those breeds, a key factor, probably the main one, seems to be a mutation in the superoxide dismutase 1 gene, SOD1 for short.
And that is the same gene linked to ALS in people. That seems huge.
It is. Certain types of ALS in humans are caused by mutations in exactly the same gene.
Wow.
So in dogs, the very first things you might notice are gradual weakness, starting in the back legs. We call that paresis.
Paresis, okay.
And also a kind of clumsy, uncoordinated walk with those hind limbs. That's proprioceptive ataxia. It usually shows up in older dogs.
So if someone sees their older dog starting to, scuff their back feet or seem a bit wobbly back there, that could be an early clue.
It definitely could be, yeah.
And if nothing's done, or if nothing can be done, what's the usual path it takes?
Well, if the disease just progresses, that weakness in the hind legs gets worse, eventually becoming complete paralysis.
Oh, wow.
And then, unfortunately, that paralysis can move forward to affect the front legs, too. So all 4 limbs become weak or paralyzed. That's tetraparesis or tetraplegia.
Okay.
And along the way, you start seeing other signs linked to the nerves further down, the lower motor neurons.
Right. So we know what it is and the early signs, but how does it happen? What's actually going wrong inside their bodies? The mechanism.
Okay, so the main trigger is a really specific genetic typo. It's a mutation where one DNA building block, a G, gets swapped for an A.
G-ferret.
At position 118.
Right.
On a specific part of the SOD1 gene called exon 2. That sounds tiny, right? But this small change messes up the protein the gene makes.
How so?
It leads to what's called an E40K missense mutation in the protein. And that specific error is the most common one we find in dogs that develop DM.
And wasn't there another one, a rarer one?
Yes, good point.
Oh.
In Bernese Mountain Dogs specifically, they found a second, much rarer SOD1 mutation. It's an A swapped for a T at position 52.
Interesting. Only in Berners so far.
As far as we know, yes. That one seems breed-specific at the moment.
Okay, so it's definitely rooted in the genes. Now, the source material also used a term, multisystem central peripheral axonopathy. That sounds complicated.
It does sound like a mouthful, doesn't it?
Yeah.
Let's break it down. Axonopathy just means a disease hitting the axons. Those are the long nerve fibers that carry signals.
Got it. Axons.
Central peripheral means the damage isn't just in the brain and spinal cord, the central system, but it might also affect the nerves branching out everywhere else, the peripheral system.
Ah, okay. So it suggests the problem might be wider than just the spine.
Potentially, yes.
Yeah.
It hints that the disease could impact nerve fibers more broadly throughout the nervous system.
And we often hear DM hits the middle of the back hardest, the mid-thoracic spinal cord. Why? Is there a theory?
Yeah, there's a really interesting theory about blood flow to that specific spot.
Okay.
It looks like that mid-thoracic area might get less blood supply compared to other parts of the spinal cord. The little arteries feeding it, the radicular arteries, might contribute less there.
Less blood.
And on top of that, the actual blood vessels in that mid-back region seem to be a bit smaller in diameter than elsewhere in the cord.
So smaller pipes and maybe less flow. Sounds like it could make that area a bit more fragile.
That's exactly the thinking. This potentially less robust blood supply could make the nerve tissue there more vulnerable over time to stresses like oxidative stress. Think of it like cellular rust and maybe metabolic problems.
Okay, that makes sense. The genetic fault starts it might affect nerves all over, but maybe there's a vulnerable spot in the mid-back because of the plumbing, essentially.
That's a good way to put it, yeah.
So specifically, which parts of the nervous system really feel the effects as the disease moves along?
Well, early on, the main target is the thoracolumbar spinal cord. That's the section running through the dog's mid to lower back.
Right.
But as DM progresses, the damage spreads. It starts involving the cervical spinal cord up in the neck and also the lumbar spinal cord further down the back.
So it moves up and down the cord.
It does. And eventually, it can also start affecting the peripheral nervous system, too, those nerves going out from the cord to the legs and organs.
It really sounds like it gradually takes over more and more ground.
Exactly. The source even mentions that neurons in the brainstem, the part connecting the brain to the spinal cord, controlling basic stuff like breathing, can get hit in some cases.
Wow.
And it's not just movement nerves. It can also affect sensory nerve roots and the dorsal root ganglia. Those are like relay stations for sensory info coming back to the spinal cord.
Man, that's widespread. Let's circle back to the genetics for a second. We talked about the SOD1 mutation. How is it usually passed down? What's the inheritance pattern?
Typically, it's what we call autosomal recessive.
Okay, what does that mean practically for a dog?
It means a dog generally needs to inherit 2 copies of that mutated SOD1 gene, one from its mom and one from its dad, to be at the highest risk of actually developing DM.
And since we see it more in certain purebreds, that strongly suggests it runs in families, right?
Absolutely. That clustering in specific breeds is a huge clue for familial inheritance.
Yeah.
And this is a really, really important point for owners. Even though these SOD1 mutations are the known cause, they show something called incomplete penetrance.
Incomplete penetrance. Okay, that sounds important. What does that mean?
It means that even if a dog inherits 2 copies of the mutation, making them homozygous, the highest genetic risk category, it's not a guarantee they'll actually get sick with DM in their lifetime.
Really? So having the bad genes doesn't automatically mean getting the disease?
Correct. They have a much, much higher risk than a dog without the mutations, but it's not 100%. Something else seems to play a role in whether the disease actually penetrates or shows up.
That is crucial info, especially for people with predisposed breeds thinking about genetic testing. So if you do test your dog, what do the results mean in terms of risk?
Okay, so if a dog tests homozygous for the mutation, 2 bad copies, they have the highest known genetic risk. If they test normal or clear 2 good copies, it's extremely unlikely they'll get DM from this specific mutation.
And the ones in the middle, carriers.
Right, a carrier has 1 normal copy and 1 mutated copy. They are considered much less likely to develop DM themselves, but, and this is important for breeding, they can pass that mutated gene on to their puppies.
So the test gives you risk level, not a definite yes/no for the future. That's clearer now. Okay, switching gears slightly, who gets DM? How common is it, really? And are there specific breeds we should know about?
Well, looking back at a big veterinary database from the 90s, the overall rate across all dogs was reported as 0.19%. So not super common overall, but definitely significant.
And it's found everywhere.
It seems to be, yeah. It's documented worldwide.
Okay, breeds. Which ones are most commonly linked?
This is pretty striking. That common SOD1 mutation, the G to A1, has been found in a huge number of breeds. The source listed over 124 different breeds or varieties.
Over 124. Wow.
Yeah. And remember, the other mutation, the A to T1, seems limited to Bernese Mountain Dogs so far. But the fact that DM itself, confirmed by looking at the spinal cord after death, has been documented in over 25 different purebreds and mixed breeds, really shows it has a wide reach.
That's much wider than I would have guessed. What about age? When does it typically start?
The average age when signs first appear is generally around 9 years old for larger breeds. Interestingly, for Pembroke Welsh Corgis, it tends to be a bit later, average around 11 years.
So definitely an older dog disease.
Pretty much. The typical range for onset is usually somewhere between 8 and 14 years old. And there's no known difference between males and females in terms of risk.
Good to know. Okay, so older dogs, certain breeds higher risk. What are the absolute first things an owner might actually see? those initial clues?
The early signs usually focus on the hind end. You might see the upper motor neuron paraparesis, basically weakness in the back legs. It often creeps up slowly. It can be quite subtle at first.
Subtle how? Like just less energy?
Maybe more like clumsiness,
Hmm.
uncoordination back there. That's the proprioceptive ataxia we mentioned. Their hind leg strides might look longer than usual, maybe a bit stiff or spastic.
Long strides, stiffness. What would that look like day to day? Scuffing paws?
Exactly. Scuffing the tops of their back paws, maybe knuckling over sometimes where the paw folds under. They might seem less stable, wobble a bit in the rear. You might also notice those paw replacement deficits. If you flip their back paw over, they're slow to fix it.
Okay, I can picture that. And what would a vet find on exam early on?
Well, the reflexes in the hind legs, like the knee jerks, are often normal or even exaggerated, sort of hyper.
What reflexes?
Okay. There's another reflex, the crossed extensor, which may or may not be there. But a really key finding, a big clue pointing towards DM early on, is the lack of pain when the vet feels along the spine and back muscles.
No pain.
Right. Unlike, say, a disc problem, which is usually painful, these dogs typically don't show that back sensitivity, what we call paraspinal hyperesthesia. That lack of pain is significant.
Okay, so weakness, coordination issues in the back, maybe hyperreflexes, but no pain. That's a critical distinction. How does it progress from there? What are the later signs?
Well, as it progresses, that hind limb weakness gets worse, eventually becoming paralysis paraplegia. They can't move their back legs.
Oh, man.
And then, sadly, it often continues up the spinal cord, starting to affect the front legs too. So they develop weakness or paralysis in all four limbs, tetraparesis or tetraplegia.
All four limbs.
You might also start seeing muscle wasting, atrophy, in the hind limbs because the nerves aren't stimulating the muscles properly. The hind limb reflexes that were maybe hyper before will likely become reduced or disappear altogether.
And other things.
Unfortunately, yes. Incontinence is common in later stages, losing control of bladder and bowels.
That sounds incredibly difficult. What about the very, very end stages?
In the final stages, you typically see complete limb paralysis of all four limbs, flaccid tetraplegia. There can also be problems with basic functions like swallowing or even moving the tongue, which suggests the brainstem is involved.
Affecting swallowing. Wow.
All the spinal reflexes are usually gone by then. That little skin twitch reflex along the back, the cutaneous truncee, is likely reduced or absent. There's significant widespread muscle wasting everywhere, and the incontinence usually continues.
It's a tough progression, but you made a point earlier about pain sensation. Can you remind us about that? It seems important.
Yes, absolutely crucial. Throughout this whole devastating process, the dog's ability to feel pain nociception stays intact. They lose movement, but not sensation.
So they can still feel touch, pressure, even if they can't move the limb.
Correct. This is a key difference from some other spinal conditions where pain sensation is lost. It's important for owners to understand their dog isn't necessarily suffering from physical pain related to the paralysis itself, even though the situation is obviously distressing.
That is a really important distinction for their comfort and care. Okay, we know genetics are central, but are any other factors thought to play a role, maybe triggers or contributors?
The sources really emphasize that DM is fundamentally a hereditary disease with that strong genetic link. But there are hypotheses out there, things researchers are looking into.
Like what?
Like maybe the immune system is involved somehow, or metabolic issues, or possibly damage from toxins, or that oxidative stress we talked about. But these are still mostly theories, areas needing more research to confirm if or how they contribute.
So sticking to what we know, the main risk factor is definitely inheriting those 2 copies of the bad SOD1 gene.
That's right. Being homozygous for the mutant allele is the biggest known risk factor by far. But like we discussed with incomplete penetrance, it's almost certain other things are involved too.
Right.
Other genes, maybe environmental factors.
Yeah.
They likely influence whether a dog with a mutation actually gets sick and maybe how fast it progresses. Research is ongoing there too.
Okay, so let's say a dog is showing these signs, the weakness, the ataxia, no pain. How does a vet actually diagnose DM? It sounds like it's not just one simple test.
That's exactly right. It's very much a process of ruling other things out, what we call making a differential diagnosis. There are several other conditions that can look similar, especially early on.
Like what kind of things?
Things like type 2 intervertebral disc disease, it's a chronic slip disc, spinal cord tumors, especially those inside the cord itself, degenerative lumbosacral stenosis, which is a narrowing down by the tailbone, and even orthopedic issues like severe hip dysplasia can sometimes confuse the picture initially.
So step 1 is eliminating those possibilities.
Pretty much. Vets will usually start with a thorough neurological exam and then often recommend tests to rule out those mimics. Standard blood work, CBC, chemistry, and a urinalysis are usually normal in DM dogs, but they're important to check for other systemic diseases.
And the urinalysis can check for UTIs too, right? Which might happen with incontinence later.
Exactly. Other tests might include urine cultures if infection is suspected, maybe thyroid tests. Interestingly, tests that measure nerve and muscle electrical activity, electrodiagnostics, are often normal in early DM, which can actually be another clue.
Okay, so where does the genetic test fit in if it doesn't guarantee the disease?
It's a really important supportive piece of the puzzle. If you have a dog showing the typical signs progressive hindlimb weakness, ataxia, no pain, older age, maybe a predisposed breed, and the SOD1 test comes back showing they were homozygous at risk, and you've ruled out other major causes with imaging, then it makes DM the very likely diagnosis.
Presumptive diagnosis, they call it.
Yes, a presumptive diagnosis. It strengthens the case significantly when combined with ruling other things out.
You mentioned imaging. What kind are we talking about? X-rays?
Could start with basic x-rays of the spine, sure. Sometimes myelography is used that's injecting dye around the spinal cord to show any compression on an x-ray or CT scan.
CT scan, okay.
But really, MRI magnetic resonance imaging is generally considered the best tool.
Why MRI?
Because it gives such fantastic detail of the spinal cord itself, not just the bones around it. It can help rule out compression from discs or tumors, but also look for any inflammation or lesions within the cord tissue that aren't DM. If the MRI is basically normal in a dog with those classic signs and the genetic risk, that also points strongly towards DM.
Gotcha. What about spinal fluid? Taking a sample of that.
Yeah, CSF analysis, cerebrospinal fluid, that's often done mainly to rule out inflammatory or infectious diseases of the central nervous system, which can sometimes mimic DM. The fluid is usually normal or near normal in DM cases.
So you do all this, the exam, the blood work, the genetic test, the MRI, the CSF tap, and you can get a pretty strong presumptive diagnosis.
Exactly. But it's crucial to remember, and this is tough for owners, the only way to be 100% certain the definitive diagnosis is by examining the spinal cord tissue after the dog has passed away.
Postmortem histopathology.
That's the term, yes. Looking at the tissue under a microscope.
That must be incredibly hard, knowing you often can't get that final confirmation during their life.
It is. It really highlights why the clinical picture, the signalment, breed, age, the genetics, and ruling out the mimics with imaging are so important for making the best possible diagnosis while the dog is still with us.
Okay, so when they do examine the spinal cord tissue post-mortem, what are the specific changes they see that scream degenerative myelopathy? What does the pathology actually show?
They see characteristic damage, mainly in specific tracts or pathways within the spinal cord, primarily the dorsal columns towards the back and the upper parts of the lateral columns on the sides.
Damage like what?
Like degenerating axons,
Yeah.
these nerve fibers and the myelin sheaths that wrap around them, they're breaking down. And this damage is usually most severe in that mid-thoracic region we talked about earlier.
Linking back to that blood supply theory, perhaps.
Possibly, yeah. They also see an increase in certain support cells called astrocytes in those damaged areas, sort of like scarring.
Is the damage pattern always the same?
Well, it used to be described as often being a bit patchy or uneven, maybe worse on one side than the other initially. But newer studies suggest that in dogs that live longer with DM, the damage can become more widespread, more symmetrical, and continuous along the cord tracts.
And does it affect the nerve cells themselves?
In the later stages, yes. They can see a loss of the actual neuron cell bodies, particularly in the ventral horn, the front part of the gray matter, and the spinal cord where motor neurons live.
And outside the spinal cord, in the nerves going to the limbs or the muscles?
Yes, they can see changes there too. Nerve biopsies might show loss of nerve fibers from that axon degeneration and secondary loss of myelin. Muscle biopsies often show a characteristic pattern of atrophy-shrunken muscle fibers that indicates denervation, meaning the muscle isn't getting the proper nerve signals anymore.
It really paints a detailed picture of the neurological destruction, doesn't it? Okay, let's shift to the really practical side. If a dog gets this diagnosis, even a presumptive one, what can actually be done? What are the treatment options, the care involved?
This is probably the hardest part. It's really important to be upfront. Currently, there is no proven effective treatment that can stop DM or even significantly slow it down.
No cure, no way to halt it.
Not that's been scientifically proven, no. So the entire focus of management becomes supportive care.
Supportive care. What does that look like in practice?
It's about maintaining the best possible quality of life for as long as possible. It often involves intensive nursing care, especially once the dog can no longer walk.
Which can be easier for smaller dogs, I guess.
That's often the case, yeah. Smaller dogs might have a longer survival time, partly because providing that intense care is just physically more manageable for owners.
So what does that care involve?
A lot. Keeping them on soft, padded bedding constantly to prevent pressure sores, especially over bony spots like hips and elbows. Meticulous hygiene is critical, keeping them clean and dry, especially if they become incontinent, to prevent urine scald.
Urine scald sounds nasty.
It is. It's skin irritation and infection from urine staying in contact with the skin. Owners also need to monitor for urinary tract infections, which are common. And physical therapy is really vital.
Physical therapy. How does that help if the nerves are degenerating?
It helps maintain joint flexibility through passive range of motion exercises. If the dog still has some movement, active exercises can help maintain muscle tone and strength for longer. It's about supporting the body they have.
What about activity? Should they still try to move?
Generally, yes. Gentle, regular exercise is encouraged as long as they're able to help slow muscle loss. But you have to be careful not to overtire them. Hydrotherapy, like an underwater treadmill, can be fantastic.
Why hydrotherapy?
The water supports their weight, making movement easier and reducing stress on joints, but still provides resistance for muscle work. And as the disease progresses, mobility assistance like slings, or more commonly wheel carts, can make a huge difference to their independence and quality of life.
Wheel carts, yeah, you see those sometimes. What about diet?
Just ensuring a good quality, balanced diet is important for overall health. And really crucial is preventing weight gain. Extra weight just makes everything harder for a dog with decreasing mobility.
It sounds like a massive commitment for owners. Educating them must be key.
Absolutely paramount. Owners need a clear understanding of the prognosis, the progressive nature, the lack of a cure, and the intense nursing demands that will likely come. They need to know what they're facing to make informed decisions about their dog's care. And it's important they know there are no surgeries for DM itself.
Right. And medications, you said no cure, but are there any drugs used at all?
Not to treat the DM itself, no.
Oh.
Again, no medications have been proven effective in slowing or stopping the disease, so there are no drugs of choice for DM. Any meds used would be for secondary things, maybe pain relief if they have concurrent arthritis, or antibiotics for UTI, but nothing for the underlying DM process.
Okay, crystal clear. So it's management, support, quality of life. How do vets monitor these dogs over time?
Regular checkups are needed. Repeat neuroexams to track the progression. Owners need to watch closely for signs of urinary retention or infection. Vets will likely recommend regular urinalysis, maybe urine cultures, and just keeping an eye out for those complications: pressure sores, skin infections, weight gain.
And the timeline. What's the typical progression speed once it starts?
It varies, of course, but a general timeline. Often dogs become paraplegic, unable to use their hind legs, within about 9 to 12 months of the first signs appearing.
9 to 12 months to paralysis. That's fast.
It can be, yes, and progression to tetraparesis, weakness in all four limbs, might happen within about 3 years from onset, sometimes sooner, sometimes later. But overall, as we said, the long-term prognosis is unfortunately poor.
Okay, so let's try to wrap this up. Summing up our deep dive, degenerative myelopathy is, well, it's a very serious progressive neurological disease in dogs. It's got that strong genetic link, particularly the SOD1 gene.
Which connects it fascinatingly to ALS in humans.
Right. It hits older dogs, certain breeds more often. And the really tough part is there's no cure yet.
Yeah, management is all about supportive care nursing, physical therapy, mobility aids, just trying to keep them comfortable and maintain quality of life.
And that SOD1 gene story, especially the incomplete penetrance part.
That's a really key point, isn't it? Having the risk genes doesn't guarantee the disease. It tells us there's more to the story than just that one gene.
Absolutely. It really makes you wonder about what else is going on. What are those other factors, other genes, environmental triggers maybe, that decide if a dog with the mutation actually develops DM?
Exactly. And that's where a lot of research is focused, trying to understand those modifiers. It also brings up complex questions for breeders, around genetic testing and breeding decisions when you have a situation like incomplete penetrance.
Definitely food for thought there, about the complex dance between genes and health, not just in dogs, but in us, too. Well, thanks for navigating this complex topic with me.
It was important information to cover. Thanks for the discussion.